All right, welcome back. So today we have a very special guest, Dr. Asamoah. We're glad you're here.
Glad to be here, Ashley.
Yeah, so you wanted to do your introduction this time. So, yeah, go ahead and share a little bit about yourself, your practice.
Yeah, because my intro is really simple. So I thought we just keep it simple. So my name is Dr. Vivian Asamoah. I'm a gastroenterologist, board certified now for 10 years, but also have a passion for integrative and functional medicine. So I blend the best of both worlds, I feel, evidence-based conventional medicine and integrative functional medicine, because I think that's a big part of what we do as gastroenterologists. My practice is based here in Houston, actually in West Houston, Katy. And I've been in practice for over a decade. And we work with amazing dietitians. And we've been working with dietitians for about 5 to 10 years now. And it's just been great in terms of helping our patients heal long term in our practice. Yeah.
That's awesome.
It is really amazing to hear. Nice. Thank you for including the dietitian profession.
Yes,
And
absolutely.
Dr. V, what made you become a GI in the first place?
Oh, that's a great question. I think GI picked me. I was really interested in many things in medicine. I was like, I'm going to do infectious disease, and then it was endocrine, and then it was this. And I had done some basic science research for a couple of years with an amazing IBD mentor, Dr. Shanti Sitaraman. Unfortunately, she passed away. I actually loved basic science and loved IBD. And when I started my rotations at Hopkins in gastroenterology, they said, "We think you'd be a great gastroenterologist." That was it. Because I think I couldn't pick. So they picked for me. And I was like, okay, sure. And I've loved it. I've enjoyed the field of gastroenterology because it's so diverse. We deal with many organs and not just one. And now with the evolution of the microbiota and the Human Microbiome Project and everything we're seeing in terms of gut brain axis disorders and the impact of that connection between the gut and the brain, I think GI is actually even just more than GI right now. It's really expanded to the entire body. So I'm glad it picked me.
So, with the diversity in the field, much like you're explaining, is there a typical day your day usually looks like?
So yeah, I mean that's the lovely thing about GI. We do procedures, right? And so I would say that my practice is probably threefold, or maybe fourfold. We do procedures, so we do regular colonoscopies, upper endoscopies. We interpret procedures like pill camera studies. Some GI doctors are doing more motility studies. So we may spend half a day doing procedures in the morning, and then in the afternoon seeing patients in clinic, and we see a diverse range of GI pathology from, Crohn's disease to liver disease to pancreatic disease. And then in my practice, my integrative practice it's very sort of specialized in everything that's microbiota. So looking at the microbiome and assessing gut health and assessing how it impacts other other diseases or other conditions that the patient may have. And some of us, well, I'm in private practice, but we still do some clinical research as well. So we have our clinical research days, sort of bringing research to our community, because community research is really important. So yeah, that's kind of like a typical day for us.
Busy.
Yes. Yes.
Are you studying anything in particular that you're excited about in research?
So I would love for the research to lean more towards the integrative, functional, but that can be a little bit challenging. And nutrition and diet-based research is very difficult. And I learned that from the conference I went to. It's dietitians are doing some amazing work in research, but there can be so much bias and lack of consistency in terms of many things. And that's the kind of research I would love to do. But right now, I think we just wrapped up a trial on GLP-1s and cirrhosis and whether it reverses cirrhosis or not. We've been looking at the new acid blocker medications, the PCABs for acid reflux, and I think we're starting a new trial on fecal micro. Well, postbiotics and C. diff treatment. So different types of conditions. Yeah.
Let's see. So postbiotics like butyrate or that like
Absolutely. Any other byproducts released by these short chain fatty acid producing bacteria that may be helpful to the gut. Yeah.
yeah. And so I know you and I were talking at the very beginning about how you've been at this big microbiome conference. Have you seen anything or heard anything really interesting that you are excited to talk about or share or learn more about?
Yeah, there's always so much information at these conferences, and you must like just to, get a good view. They are a lot of basic science, very nerdy researchers, right? Working with cell lines and mice, and trying to translate the research so that we're seeing more in human studies, but there isn't a ton. But I'm always really impressed by I think in this conference we could probably have a whole other conversation about the role of fiber and fiber being so different, right? And them actually not noticing as much of a microbiota shift with psyllium, but and them noticing some adverse shifts with different types of fiber like inulin. So it's like the type of fiber is very important in terms of how it shifts the microbiome. So that was news for me because I thought psyllium was okay for everybody. Like, it did what. So psyllium really has a great role as a laxative, but in terms of building the gut microbiota, not as much. And there's always tremendous, a lot of great research on the microbiota and its impact on cancer. So looking at what is the state of the microbiota before someone gets cancer, how do they respond to chemotherapy or immunotherapy if the microbiome is off or in good shape, and even how they can, there are some really good studies on FMT and cleaning up the microbiota and seeing better response to checkpoint immunotherapy and chemotherapy post FMT. So there's really, really great data there, and actually seeing cancer regression and disease regression. So always good data there.
Yeah, that's so interesting because I know with IBD too that there's the state of your microbiome and whether or not you have nutrition support of some kind like impacts even how well you respond to IBD meds. And it's interesting to see
Yeah.
that also in cancer. Is that
In
all
cancer, yes.
all
So
cancers are
they were looking at studies. I think they presented there's some good data on melanoma, and there's some good data on colorectal cancer. I think they're now pushing this into all different types of cancer. So pancreatic cancer was one that was also being presented. Yeah.
wow, that's interesting.
Yeah.
Yeah. So I'm curious too. So you talked about how you've created this really nice blend of both your conventional GI background, but also this integrative component and bringing in nutrition and dietitians as well. What motivated you initially to kind of start your own practice and chart your own path? Because you have not only your practice, but also a surgical center or like a
Yeah, we have our own surgery
yeah.
center. Yeah. Yeah. Um, uh, what motivated me to start the practice? Well, I mean, I did academics for about a year, and I was like, I didn't think that was me, for me because of the politics surrounding academics. I kind of knew I wanted to be my own boss. And I also knew that I would venture into things that were possibly not totally conventional. I mean, I've always been interested in herbal medicine. I've always been interested in diet and nutrition. And even as a third year fellow, spent most of my rotations with the dietitian team, actually rotating with the bariatric dietitian team, and learned how to, calculate for enteral nutrition and parenteral nutrition, and really enjoy that component. And so going into private practice made a lot of sense. And while in private practice, and seeing patients, I quickly realized that prescribing medications was not helping a lot of my patients. It really was a band-aid. And so bringing in dietitians relatively early to help manage cases, because there's a lot of stuff. I mean, as a gastroenterologist, we don't learn about nutrition. I mean, even though I did a lot of nutrition in fellowship, there just isn't that much knowledge, right? And as you know, in my practice, I was also in practice at a time where we were starting to hear a lot more about the impact of nutrition, and then different types of nutrition were coming out on social media. So I thought it was really important for me as a practice to have experts in that field be able to explain it to my patients and not just shoo them away and say, oh, it's not, it's not relevant or whatever. Really give them some education about what a healthy diet looks like and why they shouldn't go on so many fad diets that may over restrict them in many ways. So that's been wonderful. That's really been wonderful, because I think collaboration is important. And I mean, I just defer to them. I'm like, okay, what do you guys think? What do you guys, and that's been great. Yeah.
Yeah. Danielle and I talk about that all the time, how, sometimes these things tend to appear like they're polar opposites, medicine versus nutrition, instead of the integration of them is so key for a lot of people.
Oh, yeah.
And why should they be like separate and only either or, I think there's so much beauty in the integration and collaboration component of healthcare. And it's definitely the thing that's lacking a lot right now too. Sometimes you definitely feel it when you're in it.
Yeah, I do feel like it's lacking. And I think it's probably lacking on both parts sometimes, Ashley. I feel like sometimes the dietitians stay cocooned and don't reach out to collaborate. And maybe it's because of the way physicians have somewhat, kind of held, had a separation there. But I'm open. I think that collaboration is very, very important, because we don't want to misdiagnose. We don't want to catch things too late. And so I think that collaboration is really important. But I think it will come. I think I'm seeing it more and more, right? Collaborative groups. Yeah.
It's great. It's a beautiful thing.
And one of the things that we really wanted to discuss with you on the podcast today was a big piece around colon cancer, seeing as it's Colon Cancer Awareness Month.
Yeah.
Do you know, and have you read anything, or have you have any thoughts on why colon cancer rates have risen?
Yeah, that's a great question. I think we are all trying to figure that out. When we know the data is clear that about 40 to 50% of colon cancer is really related to modifiable risk factors, right? And so sometimes we think, oh, I don't have a family history, so it's not going to be in my body. I'm not going to have that because no one in my family has it. But 40 to 50% of it is related to modifiable risk factors, which are really the same ones, right? Obesity, alcohol, smoking, processed meats, processed red meat and processed meats, and then an insufficient intake of fiber, fruits and vegetable.
Mm-hmm.
And so those are all things that are preventative, right? And so if you're doing any of those things, we can see the risk go up. And many of us are doing those things. And I'm not sure that, I think the data will be emerging in terms of metabolic syndrome, because I think insulin resistance is a big one. And, the fact that a lot of us have undiagnosed insulin resistance for many, many years before it turns into diabetes is in itself a risk factor. And we're probably going to see similar studies like we've seen for our patients with IBD. There's a lot of studies now on environmental factors, toxins, air pollutants, BPA phthalates, PFAS, high risk for, we're identifying that the risk of, the prevalence of Crohn's disease and ulcerative colitis has gone up, most likely related to some of these environmental factors. And I think we will start seeing emergent data for colorectal cancer, but I think we know that there are those modifiable risk factors that play a huge role. Yeah.
And if you were talking to anybody about it, like, is there certain things that you would prioritize more so to help with the prevention of colon cancer?
Yeah, I think alcohol consumption is one we often don't put at the forefront, because it's kind of socially accepted to drink alcohol, right? And especially in women, we don't tolerate or process alcohol as well, in terms of grams and quantities, as much as men. But we are drinking more. I think we are drinking more alcohol than we had been, and I think well, we could talk about that in terms of, women are working, getting home tired. Let me have that glass of wine, going out with friends, I'll just have a second one, loneliness. I mean, many reasons why we are drinking more, right? And so I would prioritize alcohol. I would, of course, prioritize metabolism, so insulin, right, regulation, and blood glucose, really. So that goes with weight, right, to a certain extent. I would prioritize those two. Smoking is so passé. No one should be smoking anymore, but people still smoke. But it is another risk factor as well. And then when it comes to red meat, I think education. So, education is really important. But before even red meat, I would say just eating more fiber, fruits and vegetables. We're just not eating enough. So that I always encourage, at every step, more fruits and vegetables. Yeah.
I was gonna say, I definitely hear you when you're talking about alcohol. Like, we've definitely seen that one. I think it's often missed because it is so accepted and really a part of culture and a part of coping, for a lot of
Yes,
people.
absolutely.
We're not processing feelings as much with, maybe we're less social and not processing with a therapist or whatever it is. Oftentimes it's a coping mechanism or it's associated with all the fun things that people are doing. And so I've definitely seen people do pretty extreme things for health, but miss this giant thing of like, oh yeah, but you're having this every single day.
100%. Or they're like, oh, I don't drink a lot just on weekends, but that binge drinking on the weekends also has a significant impact. Just because you don't drink anything on the weekday, that binge drinking on the weekends also has its negative impacts. Yeah.
Yeah.
So true.
And I feel like there's more of this pressure when you're out and about too. People just like, why aren't you drinking?
Yes. It's like, you're boring. Why aren't you drinking?
Right. Yes.
Yeah, but I think we're going to change that around. I think that's already changing a little bit. I'm in circles where a lot of people around me don't drink alcohol, and so I guess, find your people, find your circles, right? You can have fun in so many other ways. Yeah. Mm-hmm.
Okay, so those are some big ways to help with colon cancer prevention.
Yeah.
When it comes to screening methods for it, I believe there's 3 different ways that you can screen. Are you able to explain those to us?
Absolutely. So I think everyone hears of the dreaded colonoscopy, but let's save that one for last. There is actually a blood test that came out. There used to be a blood test, but it wasn't as accurate. But there's a new blood test that came out, and it's called Shield by a company called Garden. And they're looking at DNA, non-cellular DNA. So it's really able to it has pretty good sensitivity and specificity about detecting cancer and advanced polyps, right? Advanced precancerous polyps. So there is a blood test. It's FDA approved. One thing that's important to remember with the other tests that I'll describe is that none of these tests are approved for people who are high risk. These tests are approved for people who have a low risk for colorectal cancer. They don't have a family history. They themselves have never had cancer. There's no personal history of colon polyps. They don't have IBD like Crohn's disease or ulcerative colitis that puts you at higher risk. And another one that also puts you at higher risk for colon cancer is a history of pelvic radiation. If you've had any radiation therapy to the prostate or uterus, those areas, that puts you at high risk. So these are just average people, 45, no family history or no known family history, no symptoms, and want to get it. So there's a blood test, and then there's a stool test. And you all may have seen the box, the Cologuard test, which is the stool test. So you collect your stool in there. That one's done every 3 years. There's also a stool test called the FIT test, which really is detecting for blood, right, in stool, the actual protein of blood, and that can be done every year. So there's blood, there's stool testing, and finally there's the colonoscopy. I mean, there's a variant of the colonoscopy which is called the sigmoidoscopy that only looks at the left colon. And you can do that test every 5 years, but I generally don't recommend that one because colon cancer, younger people have a high chance of colon cancer in the right colon as well. So just limiting it to just one part of the colon doesn't make any sense. So a full colonoscopy is the gold standard test. That test is ideal for patients who are getting it done for the first time at age 45 or who are high risk, have a strong family history of it. And because you actually want to go in and look for polyps before they become cancerous, right? Which is what the Cologuard test will often miss. It won't catch. It will catch cancer and it will catch very advanced polyps, but it will not catch the smaller polyps that could potentially grow and become cancer over years. Right? Yeah. So the colonoscopy is preventative, truly preventative. And the Cologuard, as well as the Shield and the FIT, are more diagnostic, kind of like there's something here. And so when that shows up positive, you got to do a colonoscopy to confirm. Mm-hmm.
And both Ashley and I, having IBD, we understand the
Mm.
importance of the scopes. But of course, whenever you talk about it or have one upcoming, it's one of those things that's like, oh goodness, here we go again. We do receive some pushback from even suggesting maybe talk to your GI about a scope when we're talking to our clients. And some people may often say too, I don't want to get a scope because it'll make me flare. How do you address that?
So that's interesting. I haven't heard that a scope will cause a flare, but I'm wondering, I mean, there are many reasons why it's like I don't want to go to the gym because, right? There you could find so many reasons why, right? But you always have to put yourself in the patient's shoes. No, I haven't heard of a flare, but one thing I do know is that a colonoscopy will alter the gut microbiome, the prep itself, right? Not the procedure itself, but the prep itself will alter the gut microbiome for up to 2 to 4 weeks post procedure. But generally, in our patients who have a diagnosis for IBD, Crohn's or ulcerative colitis, they usually have a higher burden of opportunistic bacteria. So that flush can actually be helpful for them in terms of reducing the burden. And so, no, I haven't seen it cause a flare. I can also imagine that perhaps just having a foreign body, if the disease is quite active, causes quite a bit of trauma in terms of just irritating the colon lining and causing more bleeding if they're ulcers. I could see that happening. That makes a lot of sense. But it is very helpful for us to assess disease activity and also determine if there are any precancerous, what we call dysplastic polyps in the colon. Very, very important. Yeah.
Yeah, I think that's similar to how we describe it with that it being more, I think it potentially is like a symptom irritation sort of thing rather than like a flare up. And of course, the long term benefits are just so much more important of labing something, treating something, especially in IBD where, your symptom presentation isn't always what's actually going on.
Correlating with, absolutely. And I think that it is also, we have other tests like a fecal calprotectin to detect for inflammation in the colon, right? It may not necessarily help us with small bowel Crohn's disease, but I very often, in order to assess disease severity, will do a calprotectin test rather than a full-blown colonoscopy. I mean, I think there was an era where gastroenterologists were over-scoping, and now the recommendation in trying to preserve the microbiota is, scope when you really need to, maybe every 3 to 5 years. And depending on whether you find dysplasia, you want to go in more often. But we certainly don't need to scope every patient with inflammatory bowel disease every year. That's not necessary. So I think that on both ends, right, patients may have some reservations. And I think gastroenterologists also have to, weigh the risks and benefits of a procedure that's too frequent, right? Yeah.
I think, Danielle, the other pushback we get too is like around people definitely having, understandably, myself included, dislike for prep, but now there's so many other options that I didn't know about years ago when I was diagnosed, like the capsules, and there's so many different ways that you can do it that you couldn't do it previously.
Yeah, there are so many ways. Yeah, I think, I think even beyond the capsules, I mean, you're gonna have to poop, at least 15 times and flush out. That's just, going to the bathroom. That's not going to change, right? But I think some people had reservations about fasting all day. And so some protocols, and there's some studies on newer protocols that are showing that our patients can have a very light breakfast and still do pretty well, even if they prep after. Our patients may be able to have no non-dairy based or non-milk based smoothie in the morning just to give some sustenance, right? And so I have a colleague in New York, and the patients have like scrambled eggs and a little something in the morning, and then they start the clear liquid diet at noon onwards, right? So that also helps. And you have smaller volume preps, so less volume than the full gallon. You have like a half a gallon, which is much better. And as Ashley mentioned, you have the pills as well, right? So there's one called Sutab, and that's about 24 pills. You take 12 of them the day before and 12 about 6 hours before your procedure. Still have to drink a lot of water because hydration is important. And that's easier for some as well. Yeah.
24 tablets.
I know. I wouldn't do it. I did my procedure at 45 with like a Miralax prep, and that was perfectly okay.
I
Yeah.
think that was probably my favorite that I've done. I've done all of them at this point, and I did the pills last time. And the pills, it's nice to not have to drink the liquid, but I never can make it through the pills because you just get so nauseous with them.
It's too much. Yeah.
Nausea is real
Yeah.
common with that one, I guess. But the Miralax, I think, was best tolerated for me, and I've had several patients that have mentioned that it's easier too. Is that
It's
so
easier.
the preferred is Miralax? And do you do Miralax and Dulcolax? Or?
I do. My preferred is Miralax and Dulcolax for a couple reasons. It's a lower volume prep. Our patients can mix the liquid with whatever, put a little bit of Crystal Light or whatever they want to add for taste, and it's affordable. It's not. I don't feel like you need to pay $80 for a prep that you're going to poop out, and so it's affordable. It's very cheap. And it works well. And they can just get it by themselves. They don't need a prescription for it. So I do the Miralax and Dulcolax. And then I have them take an extra bottle of magnesium citrate, the liquid magnesium citrate, if their stools are not clear by a certain time, just to kind of flush things out. And that's it. It works for at least 90% of our patients. Works very well.
Nice.
It's just really great to hear about the different options for people who may never have been presented with it. So for those listening, just know there's many out there. Well,
yes,
3 to 4 to try out. So
yes, absolutely.
Yeah. So strategy, how do you incorporate nutrition in your practice in a way to decrease risk of colon cancer? How does the key things that you?
Yeah. So I mean, I think that education, first of all, I think that the screening is very important. Education is very important in terms of nutrition. But the thing with colon cancer and prevention risk is that we see a patient one time, right? We may see a 45-year-old just for that visit, and that's it. And when it comes to behavioral change, as you both, Danielle and Ashley, as you know so well, it takes quite some time to be able to see effective, behavior change in patients, education, being consistent, reminders, flexibility options. And so when we see a patient, we see them just one time. And the most I can really do is, and I may never see them for another 5 to 10 years, right? And so the most I can often do is, recommend more fruits and vegetables. Patients who have a clean colon really don't care. But patients in whom you find polyps, and that can occur in about 15 to 40% of our patients, we will find polyps in 15 to 40%. And so in patients in whom you find polyp, I think they're a little bit more curious about, well, what is it that I can do to reduce my risk of polyp formation? And there we talk about reducing red meat, processed meats, explaining to them what these processed meats are. A lot of people don't think about highly processed deli meats and hot dogs and things like that, or even the charcuterie plate, right? And eating that in excess. Those are all processed meats with nitrites and nitrates, especially if they contain those things. And then incorporating more fruits and vegetables in different ways. And I'll usually share with them a list of high fiber fruits and vegetables and have a target goal so they understand what it is. And then just generally talking about diversifying the color of the rainbow, we always say, on your plate. Make sure you're not eating the same veggies every single time, because each one has different benefits, right? So diversifying. And, I think for me over the years, I've really tried to focus on insulin resistance. So talking to them about the Mediterranean diet and their selection of whole wheat or just more grains, and avoiding sort of enriched, overly processed flour is important. So just those things, yeah. Those nutritional tips.
Do you find that your patients ever ask to see the dietitian, or is it more so you referring them to the dietitians that you work with?
Yes, our patients do not ask to see the dietitian. They don't. I mean, I think you have certain categories, but I think the majority of them do not ask. I mean, before asking to see a dietitian, they want to get a food sensitivity test. And so usually my question is, well, have you seen a dietitian? Have you spoken with a dietitian to really understand what you're eating? And perhaps they could help you find clues in terms of symptoms and something you ate yesterday or the day before. The test may not, it's not super sensitive or specific. And I don't recommend it for most patients. And it is cash pay as well. And so, yes, very often they want a quick, hey, what am I allergic or sensitive to? Can I do the test, right? And they generally don't want someone lecturing them about nutrition. That's the honest truth. We have had tremendous success. So we put together a group nutrition program under insurance where myself or my colleague, Dr. Shea, are present with a dietitian. And we sat around and we thought about what are the 4 major GI presentations or diseases that would have a high impact if we focused heavily on lifestyle and nutrition. And it ended up being acid reflux, because we see so many patients with acid reflux. And 40% of acid reflux can be reversed with just diet and nutrition and lifestyle changes. Fatty liver, because patients are often very confused about what to eat. Can I eat fat or not eat fat? Constipation was another one. And our last one was bloating, and whether you need it to be gluten-free or not, because it may not be well suited for you. So we created an entire presentation and we offer a group discussion. So that's one people enjoy. So if you come in and you have acid reflux, and we won't just prescribe the medication, we'll actually say, well, your 2-week follow-up will be in the nutrition class, where our focus is, because we don't have time during a consult to talk about it. Our focus will just be to talk about lifestyle and nutrition surrounding acid reflux or gastritis and how things can improve. And that's a forum where there are usually several patients at a time. And those are often the best, very collaborative. Everyone is sharing ideas and, oh, you have this too, and I have this, and I tried this. And that's where I think they gain the most benefit. And that's really worked well for the sort of the general population coming into our GI practice. Yeah.
I'd love to hear that. That's great.
Yeah.
I love how you get the combination of both realms and both areas of expertise, but also the community aspect.
Yes.
The aspect of being understood by the other people that are there, so that you come in knowing that somebody gets what you're going through, which is kind of
right. Yeah.
nice.
And it feels less like a lecture of someone saying, do this, do this, do this. It's really just an opportunity to share ideas, learn from each other, and then try different things. So I think that's always the best approach.
You have me thinking now, like, oh shoot, do I lecture people?
I mean, I think as practitioners, we all lecture a little bit. We do, we're like, oh, you shouldn't do this and that. And that's hard, but we all do lecture a little bit. Yeah.
Yeah. And I think too, Danielle, if you're looking at general population, that's kind of what our career path is. Sort of the assumption, I think, is that it is kind of almost coming from a place of judgment. There's that common misconception.
People think dietitians are the food police, and we're not the food police. No, we want to help people with their nutrition choices. So,
yes, absolutely. No, you're not the food police.
No, thank you. So, you said you have a group program, you have dietitians at your practice. Those are amazing.
They're all virtual. My dietitians are all virtual, and that's worked out really well, because another thing people like to do is they like to get this information at home in the comfort of their home, and where they can show us things. Oh, this is my milk. Is this okay? Or this is what I'm using. And very often they may have a spouse or a sibling or a child there listening in to the conversation, which is helpful. Yeah. So our dietitians are virtual.
Oh, great.
Yeah. Virtual is nice. You don't have to deal with traffic. You don't have to drive anywhere, and you can probably reach more people that way too.
Yes, yes, absolutely. Yeah, we
Yeah,
offer it in a lunch hour, so you can, have your lunch and be listening in and join in, which is nice. Yeah.
that's awesome. Well,
Yes.
it sounds like you've had just a really beautifully integrated practice of having all of these realms come together, the community aspect and the nutrition and the GI. So it just sounds like a really great combination, and you've balanced it all really well. But thank you for sharing all of these great tips around colon cancer. And I guess, Danielle, do you have any other questions?
I guess one thing maybe we haven't talked a whole lot about yet is I think it sounds like you've been a trailblazer of getting dietitians around
Mm-hmm.
you.
Mm-hmm.
Is there anything that dietitians can do to kind of get in with other GIs just so that we can spread the collaboration? Is there anything you would recommend?
Yeah, I think that is happening, but it is a little challenging because gastroenterologists don't necessarily know where to find you.
Mm.
Yeah, I don't think they know where to find you. And sometimes they may feel like they already know, which we really don't, right? We really don't. And the truth is, there is still a large school of gastroenterologists who feel that nutrition doesn't matter. There is. I'm sure you've heard it from patients, right? And so getting around that mindset is really important. So I think it's really just going to be around finding your people who align with your philosophy, but reaching out to them because there's so many questions like, do they take insurance? Do they not take insurance? Do they take HSA cards or FACG cards? Is this going to be difficult? I mean, for the longest time, we really felt like our patients would only get coverage for certain diagnoses like diabetes and kidney disease and those pre-obese pre-bariatric surgery and things like that, right? So I think education is actually important. Educating the physicians around you, and not just gastroenterologists, but I feel like a primary care doctor should be heavily collaborating with dietitians. Yeah.
I definitely agree. I think we did a big push maybe 2 years ago to
Mm-hmm.
to like reach out and to
Mm-hmm.
build community with other practitioners. And one of the challenges we had was, especially if you're looking at like larger facilities, is
Mm-hmm.
it's hard to get to the people that you want to talk to. But when you do, I think it's great because a lot of people are open to learning. Like even if they're people saying that it doesn't matter, there's still a handful of those people that are very open to learning something new, which is
Absolutely.
just really great. But yeah, there's definitely a lot of roadblocks, I feel like, to it, but I do see it happening all the time, and people really starting to see how important it is at every step of the way when it comes to GI. I was going to ask you, have you had any colonoscopy? Do you have any colonoscopy stories that are maybe interesting or that might inspire someone to like
Get a
want to,
colonoscopy?
yeah, like want to
I
catch something that you didn't think you might have? Maybe this is
Nobody is inspired to get a colonoscopy. No, I don't think any story. Actually, my stories I probably should not share because everyone will get really scared about having a colonoscopy. But I think that, I don't have an inspiring story. Like I don't have a great colonoscopy story because the most remarkable ones are the ones where we are surprised to find a colon cancer. We're like, wow, she's only 40. She's only 41. And so that's something I really, really want to highlight. Colorectal cancer is the number one, going to be, or soon will be, the number one leading cause of cancer death in people under the age of 50, both men and women. And so in our 40s, we're like, oh, we're invincible. Nothing can take us down. But we are seeing, and I am personally seeing in practice, 37-year-olds, 40-year-olds, 42-year-olds, 45-year-olds with a new diagnosis of colon cancer. And I also believe that I'm seeing a lot more of my younger patients, those since the screening age is 45. Actually, I'm finding more polyps in our younger patients, which typically we didn't used to find, right? And so I think that the message that I really want to relay is that it is not a colon cancer is not a disease of old people. That is a misconception, is a myth that we really have to get out of our heads. It is actually affecting younger people. I think in the 90s, between 90s and 2000s, we saw the risk of colorectal cancer in younger people almost triple. And so it really is affecting more young people. And I think younger people have to take this very seriously and get screened, because we are able to prevent death in 90% of people if they get screened early. So it's almost like you can get a cure of colon cancer if you detect it early enough. But if you wait until you have symptoms like rectal bleeding, abdominal pain, change in your bowel habits and whatnot, it may be kind of more advanced, maybe a stage 3 or stage 4, and more difficult to treat. So prevention is really key when it comes to colorectal cancer. And so the happy story there would be 45-year-old, had a stage 1 cancer, right? Large polyps, ended up being a stage 1 cancer. Snip, snip, sent him to my colleague, the colorectal surgeon, cut it off. And they were like, Viv, we got it early. He's good, all good. Everything went great, right? That's like great news. That's really good. If we catch it early, we really can save lives.
Yeah. Well, that is
Yeah.
inspiring. So
Yes, exactly. Yeah.
Well, thank you so much for being here and for taking the time talking with us about ways people can really support their gut and prevent colon cancer.
Thanks so much for having me, Danielle and Ashley. It's been a pleasure.
All right. Take care.
Bye.